I want to thank all of you for joining us. I'm really excited for this conversation that we're about to have on how technology can help improve outcomes, improve social equity in our society and all the states that we work in. Let me introduce my guests today. We're really fortunate to have both of them. Ann Roest, she was former CIO for New York City and the former commissioner for the New York City Department of Information Technology and Telecommunications. And more recently, she ran the IES program for the state of New York. And we have Sarah Samis with us as well. She's GCOM's VP for Public Health. She has extensive experience in the healthcare sector. She comes to us from City Hall, from New York City City Hall, where she was senior advisor to the mayor and really a critical part of the COVID response. And then previous to that, she was chief of staff to the CEO for Health and Hospitals Corporation. So I really want to thank both of you for joining us. I'm really excited to have this conversation, and I'm sure the audience is really quite excited as well. So, Ann, if you don't mind, I'll start with you first.
Great.
COVID has really brought to light a lot of the social disparities that exist in our urban areas, our rural areas. What role do you feel that in your past has technology been used to really affect the outcomes in these communities?
Well, I'll mention just quickly the program to bring Wi-Fi to the streets in New York City. Mm-hmm. I think that was key. I mean, everyone needs Wi-Fi to find a job, to find housing, et cetera. So the links that you see set up around New York City, public free Wi-Fi, was one of the key programs. But the IES program that I most recently managed is about getting people their benefits more quickly, easier, and with less error. So I think that the more we can do to enable people to get the things they need, the food they need, and the housing they need, government can do a lot in that front with technology.
Oh, that's great to hear. And then, Sarah, what role did technology play in the COVID response in New York City?
Yeah, so early on, because New York City surged before the rest of the country, I think it was a great learning lab and helped emphasize the importance of technology and digital engagement because people had to be socially distant. And so one of the key major technology projects was setting up contact tracing and isolation supports. And I think one of the tenets of that was to really take the empathy perspective of the end users and the citizens and residents who were going to be needing these services, and to think about how scared they were going to be because it was a novel disease. We didn't know a cure at that point or how to treat it perfectly, and people were really disproportionately impacted, as you've referenced, across the ends of the socioeconomic spectrum. So keeping those principles in mind and thinking about the emotional state of the end user and what types of supports and services they would need if they were going to isolate. They would need paid leave, they would need food and medication delivery if they were already sick and had chronic diseases. If they had pets, they probably needed somebody to help care for their pet and do dog walking, for example. And then they would need entertainment, right? Because you're cooped up in this small space in New York City apartments for the most part, and you wanted people to feel like they could do that for the 14-day period. So I think that the design think approach and the empathy that with the people who are going through isolation and contact tracing was really important and a key part of the technology process.
You know, I want to hone in on that one word, empathy, right? I think as, technologists, sometimes we lose sight of that word, right? And what does it mean? How have you integrated empathy into the IES program in terms of that design thinking or user experience?
Yeah, it's the same approach we used in New York City when we created the design studio and design lab, that every program and every initiative you look at, you need to look at from the perspective of the end user. And so that's what we do, is we not only look at it from the perspective of the end user, but we also pilot. We take things out to the field and we have people use them and give us some feedback on just how it's working for them and make sure that they have what they need in that interface.
Has there ever been an instance where you went into a project really thinking about, this is the way the process or engagement should be with a maybe a citizen or constituent, but then going through the design thinking approach, was something completely different, like something unexpected came out of it?
Oh, absolutely. We went into one project for small business services here in the city, and it was actually the executives of the agency that had a vision, a perception of what the project would be and what outcome would be. And after we went through design think, we realized that it needed to be shaped completely differently for the customer. And All the people who participated were on board and believed we came to the best possible outcome, but it was so different than the original concept that it took a little bit of convincing to the executives that we really had the right answer. But at the end of the day, the way we presented the information to the customers on the website was so well received by the customers that traffic to that website increased tenfold.
Wow.
It was really a huge difference. And at the end of the day, the executives were also very happy that they listened. It was great.
That's great.
Yes.
And what about you, Sarah? Have you had that experience?
I'm not a clinician, but I've worked with clinicians, and I think good examples of this in service delivery are when you're interacting with clients, patients, or beneficiaries, and the information that you receive through that interaction completely changes your assessment of how to serve them. So, for example, sometimes clinicians, people come in complaining about headaches, and it turns out they're not eating enough, or they're not eating enough of the right foods. So there's inferences that or assumptions at the beginning that the clinician is making, but then they're discovering that it's a different root cause, essentially, and that the solution might not even be a medical solution. So I think that's a parallel to the service delivery aspect of the design think methodology.
And in fact, sometimes we did find that the solution, even though we're technologists, was not a technology solution. Sometimes it was just using different resources to complete a task would get the outcome at the lower cost and the more efficient approach.
Yeah, that sounds great. Now, Sarah, how were you getting that feedback from your users during this response? Everyone's isolated, right?
Yes.
And so how did you get feedback?
So there was a lot of workshop sessions up front involving persona building by some individuals who had good design think training, and they took all of the stakeholders involved. So the current DoITT commissioner, the current deputy commissioners at the health department who are leading the COVID response, and many of the staff from the Mayor's Office of Operations, from the Health and Hospitals Corporation that was leading the contact tracing effort with the health department. So the persona process really helped put everyone's mindset in the right framing to be aligned with the end users. And then there were also stakeholder engagement and an advisory board with CBOs and other neighborhood representatives.
Yeah, that's really interesting. So that a lot of that resonates of governance, that last part, right? You're having all these different stakeholders now at the table really trying to solve a problem. Now, as a commissioner of DoITT, you probably were dealing with governance challenges quite often, right? And with the external agencies. Can you talk a little bit about some of those challenges and how you overcame them?
Yeah, absolutely. I think, you see it in a lot of government. We have fiefdoms all around, and everyone's got their own priorities and their own needs. So I'll use an example and DoITT of a program we were doing between the police department and the fire department, setting up a consolidated 911 center. And it was just a matter of getting everyone in the room regularly and consistently and making sure that we had a process for everyone to have a voice in the decision making. And so we had different tiers of governance. We had the people who were actually on the ground doing the technology work, had to get together as a group across all the agencies, and we did the same thing at the executive level. So it's just a matter of getting in the room and making sure that everyone has a voice, everyone's clear on what we're doing, and with that, it's not hard to get approval and commitment from everyone.
Some of the roadblocks maybe that people put in front of government sometimes comes from a little bit of folklore, right? Though the legislation says we can't do this, or there's policies. How do you overcome those hurdles as well? Yeah,
so you really need a mediator, but I think when you ask people to show me where it says that, show me the rules. When people, it often is folklore. They haven't really looked at it themselves. And as long as you're all trying to get to the same place and you're looking at the same words, you can get around some of the issues that have been, historical and long-standing. So just taking a fresh look, saying, show me the words, get in the room. We all want the same outcomes and goals. And I think that's key also, is making sure before you start a process that everyone's clear on where you're going. And if you're all clear on where you're going and you have agreement about where you're going, then it's not hard to get over those hurdles to achieve that.
Yeah, no, that makes a lot of sense. So in at the mayor's office, I assume during COVID, there was little to no information about the disease. It made a lot of people really sick. So how did you guys get everyone on the same page, right? To get aligned everyone to the same mission? and really moving in that direction, in the same direction.
I think that the crisis situation is never a wasted opportunity, and people did rise to the challenge. And some of the fiefdoms that you've just referenced did fall away because there were not enough resources in any one agency or department's control. You really had to draw together and support each other and be flexible and realize, going back to our design think theme, that people who have different skills and methodologies really help you solve the problem collaboratively when you can get everyone focused on a singular goal, like Anne was saying. So I think that there was this urgency and public service oriented mentality that helped people to quickly meet the challenges ahead. Now, that being said, if you were given more legal flexibility, and certainly in the healthcare provider setting, the states and the feds waived a bunch of regulations that allowed operations to happen that wouldn't normally have happened in normal times. So that was very helpful. But if you could start anew, and whiteboard your dream scenario with contact tracing, to me it would have been any person contact traced could have been offered to be enrolled in health insurance through the individual marketplace or the exchange, screened for any social benefits and immediately signed up for it if they were not available and enrolled already, and connected to neighborhood organizations that offered additional services for which they would qualify. So I think we could have gone one step further and removing some of these legal and data sharing barriers to allow for more of what in the health industry we call connections to care. Mm-hmm. And by care here, I mean care for the entire whole person, not just their physical health.
No, and that's a great transition, right? So we know that when we're talking about outcomes and social inequity and disparities, that the problems usually transcend or traverse the many different boundaries of government, right? Typically someone that's enrolled in a human services program, is also enrolled maybe in WIC, is enrolled in has other health issues, maybe diabetic or whatever. So Sarah, why don't you talk a little bit about from how the use of data can inform design thinking to then solve these really difficult problems?
Yeah, I think this approach has been baked into healthcare delivery and policy for a while, and it's really exciting because I think COVID illuminated the overlap in these populations and the vulnerabilities, and how addressing people's social needs is equally important to addressing actual healthcare services. So I do think that the more you can share data about people's social needs and health needs, you'll see that there's so much congruence between the two and how much they influence each other. And there are pilots and pockets of this happening around the country. But going back to what I was saying before, we need some of these legal barriers to be removed so that more of this can be free flowing. The really exciting part is technology has advanced so much, you can process so much data that all of this data will be more useful for addressing and honing and risk stratifying and targeting your efforts on the government side once you can aggregate all the data together.
Now, from the IES perspective, it would be great to hear your view on data sharing, not only from New York City, but really around IES and the work that you're doing there.
So from IES, we're already looking at pulling together the medical and the social service information as much as possible. And the way we're approaching it is we're getting everyone to the table. They're worried about the sharing, but when we talk about people opting in, I think that gives you a path. If you ask the client, can we share your data between these organizations? They're going to say yes, because it gets them to a better place sooner. When people have to provide the same information to get Medicaid and to get food stamps and to get cash, it's just overwhelming. So bringing that all together and doing the data sharing and assuring the lawyers who are worried about the rules that people will opt in is a really helpful approach so far for the IES program.
Now, as part of IES, were you thinking about digital identities where users can actually control their data and really determine who they share with, rather than kind of more this
Absolutely, we're thinking about it. We have not found a solution yet, and I do hear that there's some rumblings about maybe some opportunities to do that I think would help the IES program. It's a technology issue that no one has successfully addressed, and I think will be really exciting when we start down that path. And I'm looking forward to that. That is what we would like to do. People can say, yes, you can share this information with those people, but not this information. I think that's going to be really helpful to get people to adopt and accept this.
Yeah. Now, when you were at HHC, I know you were part of a key player, key stakeholder in the rollout of a big EMR implementation there. Now, can you talk a little bit, kind of government, but not really government, right? Going back to the design thinking theme, you have so many different types of user stakeholders there as well. How did you deal with your design thinking challenges on how medical, like doctors use it versus nurses versus administrative staff versus patients?
Yes. It's a good challenge, and I think going back to what Anne said, having the right governance structure is so key to these large implementations where you have so many diverse use cases and end users. So for those of you who might not be familiar, EMR means electronic medical record, and it's the electronic systems that your healthcare providers use to keep track of your health information and also to drop bills for your services to your health insurance company. So it has many functions, and the governance structure for the rollout of this project at Health and Hospitals was enormous. It spanned almost 6 years. It involved every single medical specialty, had its own committee, and they all rolled up into a couple key decision makers on the clinical side. And then the billing and revenue cycle aspect also had a similar governance structure where the different roles and functions had their own committees, and they reviewed the workflows and discussed challenges and accommodations that would have to be made and changes to the workflows. So I think the key takeaway that I took from the project was that building the right governance structure up front might seem cumbersome, but putting in that time and allowing the process to work through all those multiple committees is really important for end user adoption at the end.
Yep. So let me ask one last question to each one of you, and start with you, Anne. What role, thinking now a year, 2 years, 5 years out, what role do you think, or how does technology really need to change and evolve to affect outcomes of people, right? To really better their lives.
This is a really exciting time to be in technology because I think it is evolving to a place where it will be more helpful. In the past, our big technology projects focused on things like business process management, operational metrics, so we were helping people run the operation. Now with the cloud, having the capacity and the power to process all the data that Sarah was talking about, you can use that data to make better decisions about your strategy going forward, about the decisions on what programs to implement and what the likely outcomes will be from those programs. So it's more upfront, pulling it up to the executive and the management level to use the data to make decisions about how to run their programs rather than using the data to run the programs.
That's a really good distinction, right? It's moving from running to now, how do we think about it from a strategic and a future direction?
Absolutely. We can do predictive analytics and we can see the future. If we change programs, what impact will it have and what outcome will it have?
Great. No, that's really great. So same question to you, Sarah.
So I would take it a step further. Not only is it allowing our administrators and strategic planners to more real-time shift strategies and resources in programs to target people who are really needy, but it's allowing consumers and beneficiaries themselves to take more ownership over their own individual outcomes. And it's giving them the information about how that their own behavior is influencing their outcomes. And to me, that is one of the most powerful things about technology today. And again, with the design think emphasis, if people use their own data to change their own behavior, we won. We don't need a program in the same way. That's
right. No, that's really great. So Anne and Sarah, really thank you very much for your time here. I found this this conversation really interesting and really helpful for me in the decisions that I need to do and how I can help our customers.
Well, thank
as
you for
well.
the invitation.
No, thank you. And thank you for everyone for joining.